Learning where the ACT content and content organization here. And this is today's ECG. I want to discuss about what is the diagnosis, what is the mechanism.
Okay. We'll take first.
Yeah.
그냥?
공유 부탁드립니다.
화면 공유가 안 된 거.
화면 공유도 안 되고 지금 레코딩도 안 되고 있는 것 같은데. 레코딩은 됐어요?
저기 쉐어 그러니까 쉐어 버튼을 누르세요.
쉐어 밑에 바닥에 12시, 6시. 더 잘해. 이제 보여요?
네,
네. 또?
The heart rate is about 80, and I can catch P rate, and the axis is light axis variation, and I can see RBB pattern on V1 and V2 and V3, and on V2, if I see the morphology of P wave, there is a kind of no check. So I mean, the atrium is kind of big, I guess. So I can catch that morphology of P wave. And
Okay.
I'm done.
Thank you. It's good. Lots P wave and RBBB, right?
Okay. Here is this sinus rhythm, heartbeat about 50 and quite right axis deviation. RBB morphology first complex. And also here is seen trigger mini PVC-like pattern. Then after the PVC, there is natural conduction, but it doesn't seem to conduct to the weave. It looks like non-conductive APC, but the cause, maybe it's due to the AV node refractory because of the presiding PVC. And also PVC's pattern is narrower than sinus native first complex. Then if it's maybe this or tactical region, and also initially it looks like similar to Mobit's type 2 block, but I don't think so. Maybe it could be the concealed conduction.
Okay, good. So you think that it looks like the Bobby's type 2 second degree AB block, but maybe more likely to be related to preceding PVC. And the unusual thing is PVC QRS width is narrower than the baseline rhythm RBBB.
Yes.
Okay. Okay, Washington.
I agree with that the baseline rhythm is sinus rhythm RBBB, and yes, there is notched P wave. There may be some area enlargement. Also in V1, the terminal negative deflection, the modus index is high, so the enlargement and evidence is there. And there are narrower beads which look like PVCs, and because of the concealed conduction, the next V may be blocked in the AV node. I agree with this analysis.
So concealment, right? Okay, copy. Why the PVC like pretty much bit is narrow than baseline?
I was afraid of that
You
question.
know that I always ask you why.
I'm not sure if it could be related to peeling back. I don't think. No, I don't think it will be peeling back. I'm not sure why the PVC is narrow. Because so underlying it is a right bundle branch block. No, I'm not sure why the ectopic beta is narrow. Not sure.
Okay, Theo.
It's normal to have such extensive right bundle branch block pattern all the way to B4.
Yeah, so
Is it normal?
Yeah,
It's normal.
No, it's not. typical.
somebody should say.
Okay.
Yeah.
This is abnormal, right?
Yeah.
So that may leading to your diagnosis why some patients have such a extensive right bundle branch block manifestation. Okay, that's something that you need to think in the first diagnosis. That may lead to the why your narrow complex happening. Okay, think about that a little bit.
Theo, please answer to Dr. Huang's points.
Well, the thing is strange about this ETG that the QRS, the premature bead is very narrow and the subsequent P wave doesn't conduct it to the ventricle. So I think the most possible explanations could be some premature bit from the conduction system pacing, and so that could explain the narrow QRS, and it also blocked the integrated conduction from the subsequent P wave. But still, I'm not sure that still the baseline is right bundle branch. So how could the premature bit could show the narrow QRS? But I just hypothesizing that maybe it just showed the some contraction in the left bundle. That's my explanation.
If you have a left bundle contraction, wouldn't be more right bundle? So if you have a PVC right bundle, to become narrow, right bundle have to disappear, right? Otherwise, it can happen. So unless you have actually right bundle itself a fire, then would it be narrow? Make sense?
Yeah.
Okay,
I think it's Hyung source about the balance
right.
the left bundle branch
Right,
block
but-
make narrow QRS, but it's opposite. It's
Oh, yes.
PVC.
That's what I'm
right?
trying to tell you.
So it
Yeah.
could be coming from the right bundle.
Right. So when you have a right bundle branch block or left bundle branch block, they normalize the PVC ectopic active ventricle coming from same block pattern, blocked area. Think that way. Okay?
Oh.
Make sense? So then now, can I explain this now?
Yeah, underlying RBBB.
Yeah.
If there's a simultaneous LBBB, they make a narrow QRS, balanced conduction block. But it is not a block. It is premature bit.
Right.
Yeah.
So probably the right bundle area PVC make a narrow QRS. Make sense?
Conduction normalized again.
And already Washim mentioned about why the third P-wave is blocked because of concealment.
Now,
by
can
previous-
you measure PP interval from the second complex, third complex block P wave? Is it shorter?
Caliper?
My eye looks shorter. Coupling got
Oh,
shorter.
you for this thing.
My impression, coupling got shorter. Maybe I'm wrong.
Also the
Yeah, that one to that one. Yeah.
Yeah.
So
same
same.
in the she measure on the screen.
So you say all the P wave is the same? Okay. Why I'm asking that question?
Potentially,
To
Sometimes
determine
it's
the
the-
yeah.
condition.
Right. There's a ventricular physics P
Ventricular
wave. Particularly when your coupling of a PVC gets shorter to the T, subsequent P can be triggered by the sinus node prematurely. Only reason I ask that if you look at the lead one, look at the P wave sinus rhythm, then subsequent P wave is the same. That's why I'm asking this question now.
Looks like same.
Look same? Lead one,
Lead one.
Lead one does
Lead
only,
one.
does only
P,
one P.
point
wave.
another P. That one.
Yeah.
Same?
Yes.
You believe that?
Overlap with T wave.
Yes, but the question is that is there any other lead that can tell that? How about AVR? You see? There, what are the other P wave? Very last. Is
Later
the
one,
same?
yeah.
You sure?
Don't know
I don't know now.
because it's overlap.
Okay, AVL. How about the AVL? You think same? Still?
Oh.
I'm twisting your heart now. Okay, and then look at the ABF. It's the same, huh?
Yeah.
You guys believe the same. There's a certain difference there, appears a little different, but always you need to ask that question. This is the because of premature ventricular beat from conduction system, peeling back AV node pretty quick. Whether can you modulate the sinus node or ectopic bit from somewhere? Okay. But looking at this patient, right bundle is pretty wide right bundle.
Yeah.
This is most common seen when two conditions that is most commonly with the differential diagnosis. One is congenital heart disease, post-open heart surgery.
You are.
Yes, one. Number two, Epstein. Okay. But then doesn't look like Epstein. Axis is not right, and I'm looking at this right now. So maybe this patient has some surgery, right ventricular surgery, right side surgery, congenital heart disease, something like that. So you can speculate that, okay? Because the intraventricular conduction time is very long, even the right bundle. And then T-wave pattern is very bizarre for the right bundle. So there's many things that you get subject to that. And then got extrasystole from even right bundle itself. So right bundle is a disease. So this is a favor for what we call. This is not a competitive conduction block. It's a true right bundle block. That's what we used to teach us. Okay? That's the conclusion of this thing. But this patient has fixed permanent right bundle branch block, which will commonly open or happen when you have a congenital heart surgery. All the techniques, surgical techniques, will sometimes knock it out completely right bundle. But also top of that, right ventricular overload can cause that too. So what do you think of Dr.
Yeah, I think so.
Yeah, I agree. Yeah. I think that's Dr. See more congenital disease than you guys. So. Okay. You go next slide. Okay. Okay. No, go back there. Go back there. We got to discuss this too. Now, what do you think? Why the PVC changing? Huh?
Same strip or different strip?
I think it's same strip. Am I right? Bottom one. That's the one. How about the bottom one? Bottom is a continuous strip, right?
Yeah,
Yeah, it's different PVC.
it was changing.
Yes. And then does also retrograde P wave a little bit, but that's debatable, as you said. Okay, so why the QRS axis changing?
Probably the ectopic beats are coming from different foci.
Are you sure about that? Be careful when you say that. Measure the R to R. Okay? Different. First coupling sinus to the R.
Shorter.
Second one is the longer. Kofi, that make a difference? You answer?
In which of the strips?
Bottom one. Bottom one.
Tracy.
Okay.
Yes? Coupling different. Can explain that your alternation, right? Or not? You still believe there's another focus. So, two different possible here, as you said, but what favor which one? This strip probably answered our earlier question whether that third P is different or not. If you measure PP now, even though RR interval modulation, your PP interval is same, then that's a sinus P, okay, not conducted. But the other hand, if your R to P relationship change, then this is a modulation by the PVC, okay? That is the answer. Because if a sinus node is basically parasystolic phenomenon, the sinus is going to fire no matter what. But the other hand, it is sinus node under the influence of modulation, it's going to be shorter. So they measure the PP interval again, and then we will know the answer. Okay? You can notice that it follows a different time of a T. Can you see that? The first PVC RR interval shorter, then P fell in the later. The second PVC got longer, and then it went to the top of T wave. And the longer has a little bit of a different morphology, little bit narrowish looking thing. Probably is a coupling dependent aberrant conduction, I think. That's what I think. But I think probably same focus. That's what I'd say. But
Regarding the ventricle phasing atrial arrhythmia,
Mhm.
PVC induced the change in the PP interval.
Mhm.
But if the patient underwent some cardiac surgery, probably vagal modulation
oh,
could affect the ventricle
Yeah.
phasing atrial arrhythmia.
yeah, I think there's no PVC modulation here because different falling different time, but the PP looks like the same. Okay.
And also, I'm thinking about if you look at the bottom tracing,
Mhm.
the QRS PVC QRS morphology is similar, right?
Right.
Axis is similar.
Yeah.
Only the coupling interval is different,
And then
and the upper panel
yeah,
shows
that's a
very
probability.
different.
Yeah.
So
But I think
I'm
it's the same
thinking about
focus.
what is the mechanism of those PVC. Is this related to delayed after depolarization or parasystole? We don't know, but always we saw the cardiac ballet.
Yeah.
Group beating. So probably it is related.
Yeah,
to
if you look
previous
at the
beats.
upper strip, the most you can see more regular PVC. It looks like the same interval. It looks like parasystole.
Yeah.
But
I think that PVC looks very dangerous. Second.
one. Okay, so that's the differential diagram. We can put it on. Okay, let's go to history now. Sorry, to interrupt you. Go ahead.
Okay, this patient is 39 years old male. He had a history of T-like fibrillary operation of 1004.
Oh,
And recently, he had a complication. Comorbid, there was a frequent PVC over 20 PVC. So he took the Nebivolver, but the symptom was not okay. And when he was pain between frequent PVC. Michael,
Mhm.
IRV enlargement with a severe PR was observed. So this patient, we did the VT and induction study and considering if the VT induced RFCA and could be the ICD indication, so we consider the ICD.
This patient
Oh, the blade.
the cases case that I oblated
Yes,
yesterday.
That's why you blade the right side. The
Yeah.
right side. Perfect. Yeah, that's what it is.
At first I oblate PVC.
Right.
And PVC was originated from perimembranous septum.
Right.
adjacent to the fused pitch. That's why
narrow.
that area is, the conduction system is
narrow.
located just next to the perimembranous fused
Patch,
pitch.
yeah.
So that's why the TBC is narrow. The TBC originates from just next to or adjacent to the conduction system. And then I ablate the slow conducting anatomy isthmus.
No ICD.
Uh,
Will you or not?
he is supposed to implant it pulmonary valve. So pediatric cardiologist would like to implant PPVI before ICD. Because if I implanted ICD lead, pediatric cardiologist may have some trouble to implant
Right.
the pulmonary valve. So I have a plan to implant ICD after PPVI.
So ablation first,
Yes.
always.
You did already.
And percutaneous valve, pulmonary valve,
And
then
then
the
ICD.
ICD. But my question is, this patient's is ICD mandatory? or not?
He has three kinds of three risk factors of sudden death. First complex is 190
Right.
millisec and non-sustainability during Holter monitoring and non inducible VT in EP.
Oh, it was inducible.
Yeah. And then AV node Wenkvar was 600 millisecond when he started. I was watching his shoulder a little bit. Just
But you ablated non-sustained VT and
PVC couplet.
According to the
not
guideline,
inducible.
according to the guideline, we have to implant ICD
It's structural heart disease, so
irrespective of, regardless of success or fail of catheter ablation.
because the cath ablation is there's no long-term data. And also this is, you have to remember, congenital heart disease scar, so it tends to progress. They don't stay. So to make sure you cover your patients, okay? And particularly this patient can develop heart block and sudden death also. So it's two mechanisms, not just one. And the indication ICD is a very appropriate type of patient. Okay. Now question that, do you do subtle CSP ICD on this guy?
Not available.
Yeah.
I think it would be a good idea. Huh?
Yeah.
Think about it.
Yeah.
Mm. At least to think about it. So because the QR is too wide, so those pacing would not benefit. Might as well give benefit of CSP as well. Okay. That's it. Great. Any-
Okay, so also there are brief.
Sure, absolutely. I'm sorry, interrupt.
Depends on AV block. Paroxysmal AV block is important, but often underrecognized cause of syncope or cardiac arrest. Here it is characterized by sudden transient failure of AV block conductions despite the previous lower AV connection. Most common mechanism is cause dependent. Phase 4 AV block occurring in the disease frequency tissue. After the ectopic beat, a compensatory pause develops, and during the prolonged pause, abnormal spontaneous depolarizations occur in the disease frequency system, leading to the sodium channel inactivation and the result, the next sinus impulse cannot conduct it, causing the sudden AV block and ventricular standstill. AV conduction is often restored by the critical timed escape beat or ventricular ectopic beat that resets the his frequency membrane. This example demonstrates the typical sequence of the pulse-dependent paroxysmal AV block. Initially, there is the normal sinus conductions, then a ventricular ectopic beat occurs, followed by the compensated pause. And because of the prolonged pause, the disease is frequency system becomes partially depolarized and unable to conduct the subsequent sinus impulse, so resulting in a prolonged ventricular standstill. Because of an important clue is that the sinus blade accelerates during the AV block, affecting the rising adrenergic tone and helping to differentiate this condition from the vaguely mediated AV block. Finally, junctional escape bit or ventricular atrophy bit reset the conduction system, allowing the AV conduction to resume. Differential diagnosis. So first, cause-dependent AV block, phase 4 AV block, is caused by the disease inflammatory His-Purkinje tissue, and it is typically triggered by the pulse or ectopic beats, occur suddenly without the PR prolongations and usually require permanent treatment. Second, the vaguely mediated AV block is caused by the increasing parasympathetic tone at the AV nodal level. And unlike the phase 4 AV block, it is usually preceded by the sinus slowing or PR prolongation or prodromal symptoms such as nausea and diaphoresis. Third, tachycardia and accelerated dependent AV block, also known as the phase 3 AV block, occurs at a faster heart rate and when the disease His-Purkinje tissue is still refractory. In this condition, increasing heart rate worsens the conduction, while slowing the heart rate restores the AV conduction.
I think this patient before the operation, he is about 25% of PBC. After PBC, AV block occurred. So I suspicious of conduction system disease. However, after PBC ablation, there is no AV block. So I think
We still need a device.
Should we call it just concealment or phase 4 AV block? Perhaps it is not
That's
phase.
my question. But usually the phase 4 block make a long,
Yes,
the
But also-
consecutive several
Yes.
beats of AV block at least, but it was just a single beat. So
He
I
said
guess
it is a block. He's just
Yeah.
telling us.
Okay.
During the clinically, there's a lot of PVC and a few is a block.
so. I'm talking about the mechanism.
Sure.
So it could be the PVC increase AV node put the AV node on the refractory period to make a single beat block.
Yes.
So I think
is
that
different
is
from
not the
paroxysmal AV
phase 4 block. Actually, it is rather the match to the concealment.
There is a syndrome called MEPPC. Have you heard that?
What is that?
It's a multifocal ectopic Purkinje premature contraction syndrome.
Oh.
The sodium channel mutation. For the guys, I just can't remember. I'm sorry about that. Anyway, it is a sodium channel mutation, and those patients have all the same pattern. So you need to differentiate diagram. I'm just going to talk about that a little bit. So they have a paroxysmal heart block. They have a multifocal premature from Purkinje fibers, a multifocal fascicular pattern of a narrow complex VT, all non-sustained VT PVC, and then they also have what you're talking. So it is pretty similar to this, except those patients don't have this stuff, congenital heart disease, scar, none of those stuff. That's a difference to diagnose here. Okay, read about MEPPC. There's many paper written. Okay, that's education for you guys today.
MEPPC.
There's a best paper written by American group. They have over 30 patient series. I know there's a series of paper published in China, from Netherlands, from all other areas. Last time I reviewed this, I think it was 2022 or 23, something like that. I don't remember. Anyway, those patient has read about it. It's a very interesting disease. It's a sodium channel mutation. Okay.
But as far as I know, the Facebook block is raising of basal membrane potential. So it should shows a consecutive conduction block. So single block may be related to PBC related AV nodal refractory. Of course, this patient definitely has a conduction disease. The definition wise, mechanism may not be the phase 4 block.
Is it possible that your extra systole conceals the since originated from the right bundle and prematurely make a left bundle pattern? So you may have a transient gap time between the recovered left bundle because you already premature depolarization. They basically kill that left bundle as well as AV node. That may cause heart block. But it is just only you can measure by transceptor conduction time and so on. So that would be the explanation. But there's a 2 consecutive block right there. Okay, 3. So maybe it's but considering yesterday AV nodal conduction curve in a patient may have intrinsic AV nodal conduction disease as well. Who knows? Because your ventricular cycle too long, 600 milliseconds. That's who this surgical procedure sometimes damage the AV nodal and whole 9 yards because they stretch and do all that mechanical injury to the cardiac tissues there. Especially putting a BSD such a patch such a close the AV nodal area. That may
I operated single point.
yes.
For PVC. However,
Two distinctions appear. Right. Yeah. I think that's probably that the same focus as chip on actually. Quick learn. What did you find the paper? Amy PPC?
I'm sorry that I'm searching the chat.
Want me to send the paper? I think I have a paper somewhere.
Why don't you read the textbook and journal? Searching the chat.
I can find the paper for you. You want me to send it to you?
It is extremely rare genetic disease.
Yeah, it is. But it's similar to this.
Okay.
Well, actually, genetic disease doesn't need to know. Well, so story is telling me. Okay, very good. Any more to present?
Done?
Good.
Okay, thank you.
Wonderful. Rare disease structure 많이 알아야지. So you're not going to see often. You gotta remember.
Good morning. I'm Kopi Tichiasamo, and I'm presenting today's EGM case. This EGM case is not necessarily a rare thing. It's quite common, but I think there are still significant learning points for that colleague fellows can benefit from, which is the reason for this case. So this is the case of a 30-year-old female who reported with sudden onset and offset palpitations, with each episode lasting less than 30 minutes. The history included 3 previous episodes of syncope, 2 of which occurred during the symptoms and 1 during tilt table testing as part of her evaluation. Her echocardiogram done was normal. This is her ECG, which looks like a normal sinus rhythm. And she had a chest X-ray done as well, and we see a very small and vertical heart. Otherwise, there isn't maybe a bit of spinal curvature, but aside that, it's essentially normal. So at the beginning of the EP study, this was the catheter placement, the duodeca in the RA into CS, and then quadripolar catheters in the at the HIS end in the RV. And baseline intervals were as follows. Cycle length was 875. Yes, cycle length 875, AH interval 52, HV 37, and QRS duration 90 milliseconds.
Sorry to interrupt. You're showing the previous slides by Dr. Che.
So which slide do you see currently?
Dr. Chen.
Just phase 4
Oh,
AV block.
Sorry, I didn't share. Sorry. Can you see now?
Yep.
The catheter positioning.
Yes. Good.
Okay, thank you. So the baseline EGM measurements as follows: cycle length of 875, AH interval of 52, HV interval of 37, and QRS duration 90 milliseconds. On RV pacing, the earliest A was in the CS. So this line over here marks the earliest A in the HIS bundle, but we see that it's preceded in CS34. So that's measured by this red line. So earliest A is around CS34. VA block cycle length was at 320 milliseconds. And on single ventricular extrastimulus testing, VA decremental property was observed. Ventricular ERP was at 600 to 50. During straight RA pacing, we noticed Wenke-Bach behavior at RAP 460. We can see progressive prolongation of the AH interval. And at RAP 420, we see sustained slow conduction where the PR interval is longer than the prevailing RR interval. And this is demonstrated here. So we see how the P waves are initially matched perfectly with the QRSs, and then they start crossing over around here. So this matches to that, and this matches to that. So this is the sustained slow conduction phenomenon. AV block cycle length was observed at RAP 400 milliseconds. And atrial ERP was less than 600, 200. So during single extra atrial testing at 600, 320, here we notice that there's an AH jump of 290 milliseconds. And then there's a beat here, and then it initiates a tachycardia. Now, this is the AH jump. And so we see the A matching to the H and the H matching to the V, but this beat occurs actually just a little before the H, which suggests that this is unlikely to be an echo beat, but rather probably an atrial premature complex that just coincides with this AH jump. And then it initiates a tachycardia where we see the HIS spike first. It's not easily visible, but we see a HIS spike first. And then we have a short VA tachycardia over here. So measuring the intervals, the cycle length was 406, AH interval of 264, HV of 41, and the QRS duration of 67. And in this tachycardia as well, the earliest A was around the CS4. And this is the termination of the tachycardia. So we see that we have the tachycardia beats, and then the activation sequence begins to change. Looking at the V to A relationship, we see over here the VA relationship, and then the A starts to precede the V, and then eventually the tachycardia terminates. And then we induced tachycardia again. We have an AH jump, but then this time the tachycardia morphology, you notice is different. So again, that's the A matching to the H and the H matching to the V. But from the previous tachycardia, we realized that the atrial activation is different in the CS leads. Initially, CS34 was the earliest, and they had a bracket kind of morphology. Over here, we see that it's following more of the sinus morphology, and we have a much wider VA interval. So this is a long VA tachycardia. So this is just showing the difference in activation. And this shows us the VA prolongation. So these intervals are also measured. AH was still prolonged, which suggests that this tachycardia is likely utilizing the slow pathway in conducting down the ventricle. And this was the surface ECG during the tachycardia. So this is a comparison between the two tachycardias. The first tachycardia that was elicited, we see this pattern of A activation right here, and then we see the VA relationship. When we come to this tachycardia, we see that the A activation pattern is different, and then the VA relationship is much longer. Now, during the second tachycardia, if we focus on the CS leads, we realize that there's a change in the VA. So noticing this relationship over here, over time, the V and the A become much closer. So then the tachycardia sequence begins to change, and then it transitions into the first tachycardia. So here we see the relationship between the each A and the V, and then we see how it changes from the A preceding the V to the V now preceding the A. And then we also see that the atrial activation sequence changes in the CS leads, which tells us that there is actually a change in the tachycardia. So the tachycardia intervals were measured after the change as well, and this was the surface ECG at that time. So following the change in tachycardia sequence, re-entrainment revealed a PPI TCL of 169 milliseconds with a VAV response, and V reset was negative with a His refractory VPC. And after tachycardia termination, slow pathway ERP was identified at 600 to 40. So in summary, we have a patient who had the earliest age during V pacing at CS34, evidence of dual AV physiology, and was able to elicit 2 narrow complex SVTs. The first one had a short VA interval with earliest activation around the CS34, and V reset was negative. V entrainment also showed was 169. Then we had a second tachycardia, which had the earliest activation in HRA 1920 with an atrial activation following the sinus pattern. So at this point, 2 diagnoses were considered, AVNRT and then a probable atrial tachycardia, given the direction of activation probably from the high crista terminalis area. So we set out to ablate to ablate the slow pathway. So this is the catheter positioning in LAO and RAO. And so pre-ablation, we have the slow pathway potential noted over here. And during ablation, we observed junctional rhythm. Now, after ablation, EP study of single extra atrial stimulus testing again elicited tachycardia, but this had the morphology of the second tachycardia, not the first tachycardia, where we have the long VA interval. So that's the A matching to the H and then H to B, and then we see the long VA relationship and the second tachycardia pattern of atrial activation. And we measured the intervals here. The AH was narrower than previously. And after termination, we had the ERP. And then it was induced again, same pattern as tachycardia 2. So then at this point, we decided to map for an atrial tachycardia coexisting with the AVNRT to determine exactly where the focus was. And so here we see the grid catheter positioning in the high right atrium. And the grid map showed an early activation in 1314 from compared to H1920, which was the earliest activation on the diagnostic catheter. We attempted to entrain, and over here we see that the rate we attempted to entrain at 400 milliseconds. We see that the rate is as was paced, but we don't see any progressive fusion over here. And on termination of pacing, we see that the original tachycardia is restored. Now with entrainment, you would expect that there will be progressive fusion before it takes over the rhythm. We did not see that. Then again, one may argue that in concealed entrainment, if the catheter is within the circuit, then you may not see progressive fusion. But if that's the case, then on termination, you would expect that the rate would be approximately the same because you are pacing from within the circuit. So from this, it shows that entrainment was unsuccessful, and so it was unlikely to be a reentrant mechanism. Activation mapping showed this pattern. We see a focal pattern with the earliest break in this area. which again which was in the superior posterior area near the high crista terminalis. So in summary, we had tachycardia 2, which showed LS activation in HRA 1920, and treatment was unsuccessful, making it unlikely to be a reentrance mechanism. 3D activation mapping showed LS activation in the superolateral RA high crystal region, and was repeatedly inducible by PES. PES is good for identifying re-entry and triggered activity mechanisms. So possibly this was a triggered activity mechanism. So we made a conclusion of a focal atrial tachycardia arising from high crista terminalis. Ablation catheter was positioned, and we can see here that it's preceding the H1920 by 19 seconds. And this was the positioning of the catheter. On ablation, atrial tachycardia terminated within 12 seconds, but it was reinduced at a point, and so the catheter was repositioned. And this is a final map showing the ablation points. Then after that, we had another induction following the sequence of tachycardia 1, which suggested that the AVNRT had recurred. So catheter was repositioned at the slow pathway area and ablated. And this is the final EGM and the final of the ECG. Thank you very much.
Question?
Can we go back to your first tracing?
The first sinus.
Yeah, first sinus, and then let's go down to the tracing. Yeah. You had the the jump and the induction of tachycardia. Okay, next slide. Let's be pacing. So basically, you're showing that the patient has dual VA conduction, septal and the CS, right? That's what you're showing. So patient had basically fast slow fusion here. Okay, let's go. And then it's also typical. Okay. Keep going. Keep going. Three more. Yeah, keep going. So basically, what you show over there is a basically crossover phenomenon we see quite a bit in pediatric age. That's nothing uncommon. Patient slow pathway. Okay, keep going. Okay, here. What do you see?
You see S1.
Yes.
Marching down.
S2.
Down. S2 captures the atrium,
But no
but
V.
there's no V, and then
there's another APC.
an APC.
Now that APC is a sinus rhythm. What kind of rhythm is this?
Looking at the activation, it doesn't look sinus.
Yes, so where's it coming from? It's called the inter-atrial echo. Or is it AV node echo? What do you think? What do you think it is? Or trigger PAC? You have a 3-beat, pretty similar, but not quite similar. Okay, especially 3 beats, ectopic atrial beat, or whatever, non-sustained AT, because the rate is slightly irregular. Isn't that?
Yes.
So you could be some sort of a non-sustained atrial tachycardia, and tachycardia. Could be some of those. Okay. Anyway, also CS activation pattern change. That's the favor for probably non-specific response. Okay. Next slide. Here. What happened here?
Here there's an AH jump. And then I think this is an APC.
APC from where? The same tachycardia that you ablated?
Yes, this looks like it's from the high right atrium.
Right.
H1920 is the earliest.
So basically pacing had to have another conduction. At the same time, figure single bit of a crystal tachycardia, which further enhances the AV node conduction, causing two AV node reentry, right? Yeah. What is unusual about this? Look at the HRA timing with the CS, which is earlier.
HRA with the HRA.
Next bit I'm talking. Next bit.
This one?
Yeah. Is that typically what you see in AV node reentry?
No, that's not typical.
That's not typical. Higher rate earlier than it should be. So what's the difference of diagnosis here? If it indeed this was AVNRT, what would you say? This is a so-called Japanese guys called superior anterior AV node pathway. There's a slow pathway anterior AV node. You know that we talked about a little bit. Looks like this. Okay? Because higher atrium septal area become earlier than CS. So you may want to read about that paper. Okay? It's important difference of diagnosis. This is rare diagnosis, but it exists such a disease. Okay? So indeed, this your argument, this is AVNRT. Somebody going to argue with you. How come your higher atrium earlier than CS if it's AV node reentry? You can. The second thing is that I don't see P wave very well, but it doesn't look like a negative to me, especially AVF. Okay? So we need to justify that. Or patient has a what? Other explanation? Double tachycardia going on. Okay? Simultaneous. It is such a thing. There is a double tachycardia well reported fascicular VT with AVNRT, so on. Because AVNRT is a disease that doesn't need anything else. Therefore, it's a room to have another tachycardia nature and coincide together. Otherwise, you can explain this. Okay? So first tracing up right up front, make a very unusual looking tachycardia. So I think you must make
point out
that.
which one is unusual. I could not catch you.
You like that me?
Yeah.
Okay. So if you look carefully, AVNRT, posterior activation is earlier than HRA. Look at the HRA where it is.
That is earlier. No?
This is
Three-
earliest.
Actually, should be late.
3-4.
CS34 is later. Yes, through the line. CS34 is not early, okay? Because your wavefront is breaking up between CS5 and CS34, positive and negative. You see the second bit there during the tachycardia, you can see. 534 is a negative, 56 is positive.
Yeah, so the last bit is hiding the cutoff.
So I think,
is later.
yeah, HRA is a little bit earlier than we anticipate in AVNRT. That bothers me. HRA should be a little later than CS because his bundle coming out.
Could be fusion with atrial tachycardia.
That's what I said, double
Yeah,
tachycardia.
yeah.
Or anterior slow pathway. The Japanese guy described this. In the ERA, there's a case they presented also. Unless you guys slept over in ERA conference, but there is a case to report.
I'm sorry, I never seen that.
So this is a different diagnosis you need to think. when you see
Except
this.
for in the paper.
Okay, let's go. Keep going. Yeah, this have repeated again. You see that last one again? Go again. And then during the tachycardia also happen. In and out of it. Okay? Keep going. There's another case yeah, there you go, right here. Take a look at it. You see your CS activation overtaking by the atrial tachycardia, and then go back again, back and forward. So this is the evidence that the patient has a double tachycardia simultaneously going on right now. There's not a one tachycardia. Okay? It's a very interesting case of that nature. Because also you look at the HRA timing of the CS, keep varying. You look it up. Become later, earlier, so on. So this is an AVNRT with an activated tachycardia going on back and forward. That's why P wave looks very funny. Look at the surface ECG. There's no typical retrograde P wave usually. Okay, diffusion. In other words, probably right atrium is a right atrial tachycardia. CS is AVNRT. That's what I think.
But how come
But
the
in CS,
two
it's
tachycardia cycles similar? Is it the coincidence or
It's
tachycardia that provoked the other one?
I cannot prove you that. So we have not mapped whatever collision wavefront, where all that. But then I think I assume that the two tachycardia are going on. That's what I can say, because you look at the degree of fusion going on. Look at the HRA signal. Okay, top first one, second or third one, and then last bit go back to the atrial tachycardia again.
Right.
You see? So I think because the degree of fusion vary, I think it's a double two tachycardia going on at the same time. What mechanism? I don't know.
but
Yeah.
here CS34 is earliest.
Yes, CS34 earlier, then become change. Look at the first bit. CS34 is earlier? No, later, right? Very first bit. And then P precedes the QRS complex. And then we become second bit HR is earlier still. And then gradually CS become earlier. As your HRA potential gets smaller, your CS become dominant now. And the last bit, back to HR again. Okay? If you look at the last bit, you agree that the HR is earlier, right? Because barely CS, but HR is clearly visible. Slide the cup right at the line.
Interesting finding is that if you look at the CS electron polarity,
Mm-hmm.
first one is AT.
Yes.
From second one,
Fusion.
it looks like the
Fusion.
fusion
And then
and
next AVNRT.
NLT. But
Yes.
the right side, first, second, third bit looks like the AT and fusion.
Fusion,
right?
yes. And then last bit is back to AT again.
In other words, the RA and LA activation
So separate.
is quite different.
That's why I said that to a double tachycardia. Okay? That's the whole point of this slide. Okay? Any other idea, Kofi?
During RV pacing, you also showed that there was an eccentric activation.
Right. So I think patient had a double tachycardia. Now question is, which one causes syncope this patient? Atrial tachycardia or AVNRT?
AVNRT more likely.
Yes, AVNRT.
At the baseline, the pre-pacing, it looks like eccentric, but the CS catheter was not deep inside. That's the reason.
Yeah.
This was
Yeah. So CS 5-6 actually also was CS, maybe roof of CS very proximal, and then 3-4 is slightly in. So that's probably what it is. So then last portion that after the blading AVNRT, you only induce the activated tachycardia. And then, but I have one more question for you. Show me the 3D map. 3D crystal ablation. It's just for the, next bit. Next slide. No, there was a 3D mapping ablation point.
yes.
Yeah, I want to see the ablation point. Yeah. Now, I have a cool question for you. Do you have any additional map beside this? Why I'm asking that question? Where you ablated over there? So when you're ablating high up there, SVC junction, I assume that's the red dot is in the SVC junction?
Yes, so SVC junction.
Yes.
For the crystal.
Yeah. What do you do? What do you have to be careful up there?
The SA node.
SA node.
No.
Okay. Do you have a sinus node map? Sinus rhythm?
Yeah, I did.
Yes.
How come you did not show that?
And also Fragner.
Yes.
Yeah, that's why there's so many.
Right. It is
this
important.
first
Yeah, it is important when you're messing around that area. You get a sinus node activation map first before you think of blading, because you can cause a six-sinus syndrome these people. Okay.
young patient.
So you really need to make sure that you put baseline map of a sinus node, identify where the sinus node pacemaking activity is. Now, sinus map has to be careful. You want to do with the isoprene fusion. You don't want to do without it. Normally, you can have a two sinus rhythm activation, a little bit lower to the crista, other one to high. So if you don't have a catacolumn, you're not going to be able to find the true sinus node of rapidly firing node function. So we isoprel, create good sinus node map, free node reset, and then you, based on that map, you're going to map that to get the tachycardia. Make sure that tachycardia focus is different. If not, you got sinus node reentry. Then you need to do differential maneuvering from there. So this is the important part of your work, okay? Another thing that I would do one more time, thing is that in this map, in the right side, you see that his bundle tagging they did, golden tag? Yeah, you want to make it that wide as you can, okay? That's how that device for you.
There's a slow passage ablation point, red spot.
Red spot, yes. But then you have to ablate twice.
But the first one, I didn't use 3D map at that time.
That's no excuse, okay? Come on.
That's why there's 1 point.
Nobody uses it. Come on. But you become a US, everybody uses 3D to play SVT. That's crazy. No. So I think it is something that your teaching standpoint is important to recognize what structure ablating, where are you, what are the potential complications. So I can only tell you guys what not to do, okay? You can do anything else what you want to do. All right? So please map the sinus node. All that. Okay?
This patient, the sinus node exit site is a little away from the target site.
I'm sure it is.
I use the high output pacing during
Right.
burn. So always it matched the frame of capture.
So high crystal tachycardia ablation, sinus node map first, then you ablate the crystal focus, okay? Don't mess around, especially subtle vacuum bond the same way. All this is important maneuver you have to do. You know, ablating is a good thing, but then you need to have a safety measure first. Normal people. All right, good teaching. Great.
Overdrive the atrial tachycardia, but did not entrain it. We only overdrived it, but did not entrain it.
No, there's if you have a focal tachycardia, you pace right on the top of that focus, you will entrain exactly the same.
Oh.
Okay, so that's one of the rule exclusion of, but there's no progressive fusion. So in other words, you keep pacing closer to the focus, you're still getting closer in the rhythm tachycardia. In the focal tachycardia is suppressive, but at the falling right on the top of it, you're going to entrain. It looks exactly the same. So it cannot be differentiated. Okay, that's the difference.
And we can also see the return V at different cycle lengths. If it varies, it's
Yes,
favors
should be
AV.
vary because there was, if you look at the notice that during the V pacing, there's a proper linking between A and B. Remember his slide? Yeah.
Today I would like to talk about unusual affective pathways. There are 6 kinds of unusual pathways. I would like to explain the bottom line. Ludovascular pathway has atrial proximal insertion at AV node. Distal insertion is right bundle or vesicle. Next, nodoventricular pathway. The atrial insertion is AV node. Distal insertion is ventricle myocardium itself. Next, vesicular-ventricular pathway. The proximal insertion is vesicle or right bundle. The insertion is ventricle myocardium. Next, atriovascular pathway has proximal insertion at node-like structure at atrial tissue. Distal insertion is vesicle or right bundle. And next, atrioventricular pathway is similar with the usual pathway. However, the node-like structure. So this unusual affective pathways is decremental AV conduction because of this node-like structure or AV node insertion site. And VA conduction is no VA conduction or decremental conduction. And let's move to vesicular ventricular accessory pathway. The atrial proximal insertion starts from vesicle. Because of this reason, the pre-excitation is minimal and fixed, and HV interval is longer than 10 millisec. However, another pathway, for example, atriovascular or nodovascular accessory pathway, pre-excitation degree is larger than this one and may change atrial stimulation because atriovascular pathway has 2 pathways. One pathway here and the other conduction is through the AV node. So when it comes to ventricular activity, there are 2 inputs. So if we pace atrium that compete, two conduction pathway competes for ventricular excitation. So pre-excitation degree can be changed by atrial pacing, like a usual pathway. However, vesicular ventricular pathway, there is only one connection between atrium and ventricle. So there is no competition for ventricular excitation. That's why the pre-excitation degree is minimal and fixed, and HEV interval is also same. The pre-excitation degree and HEV interval mechanism of change in pre-excitation degree and HEV interval is almost same. And next, adenosine response. Nodovascular and vascular ventricular access pathway. If we inject adenosine, then AV node is blocked. Then no ventricular activity just after adenosine injection. However, usual access pathway and atrial vascular access pathway, if we inject adenosine, AV node is blocked. However, the conduction through the accessory pathway is still going on. So no AV block appeared after adenosine injection. And next, multi-site apacing. This means the competition of two conduction system. If we pace, let's think of the atriovascular accessory pathway like this. If we pace here, then this activity may go via normal conduction system mainly and less through the accessory pathway. However, we pace here, then this activity goes through the accessory pathway mainly and less to the conduction system. So that multiple apacing makes delta wave degree, change in delta wave degree. However, on nodovascular or vascular ventricular pathway, there is only one proximal insertion. So if we pace anywhere in atrium, only a single morphology of the delta wave. And His-bond pacing also same story. And if we pace in the patient with vascular ventricular access pathway, if we pace His-bundle, still we can see the still pre-excitation. However, another pathways, if we pace His-bundle, then we cannot. Delta wave will be no pre-excitation. Okay, let's move to cases. 31 female complaint of recurrent palpitation. This is her ECG on rest. Sinus rhythm. We can see the small delta wave here. Sometimes PAC appeared. However, after PAC, delta wave morphology almost same to sinus rhythm. We conducted the EP study, catheter position like this. This is electrogram during the sinus rhythm. This is His-bundle signal and QRS onset here. HEV interval almost normal. Even the delta wave is still here. We conducted V study. VA conduction is concentric and decremental conduction. We conducted A study. No delta wave augmentation during A pacing. Okay, compare the sinus rhythm delta and delta wave after A pace. And we can observe the AH decremental property. We conducted multi-site A pacing, higher A pacing, lower A pacing, proximal CS pacing, and distal CS pacing. All the same, we can see all the same delta wave, minimal delta wave. There's no change in delta wave morphology, even by multi-site A pacing. We injected adenosine. We can see the AV block just after adenosine injection. We conduct His-bond pacing. This bit is atrial capture, and this bit is ventricular capture. This bit is His capture. Okay, let's compare it with A capture and His-bond capture. this one and this one, almost same delta wave. So if we pace his bundle, still pre-excitation appeared. So in this patient, AV conduction is decremental, VA conduction is also decremental. Pre-excitation degree is almost fixed and minimum. HEV interval same. We inject adenosine, we can see the AV block. Multi-site A pacing, no effect on delta wave. This bundle pacing still pre-excitation, no inducible tachycardia, so we didn't ablate this pathway. This picture depicted the unusual access pathway. This is compact AV node and penetrating bundle and right bundle, left bundle. The ventricular connection is this one, and this connection is nodoventricular pathway. Next case, 60-year-old female. She complained of recurrent palpitation during during ECG recording when she rests. We can see the delta wave, minimal delta wave here. However, sometimes PAC appeared. Just after PAC, we can see the right bundle branch block pattern. PR interval is not short. Delta wave is still small. PAC induce not delta wave augmentation, but RBBB. That means this pathway, proximal insertion of this pathway is distal to right bundle. So that means vesiculoventricular pathway. Next case, 37 years old male. He complained of recurrent palpitation. ECG showed delta wave here. Yeah, not very small delta wave. We conduct EP study, catheter positions like this. During sinus rhythm, his bundle potential may superimpose the ventricular activity. This is his, yeah, and this is onset of QRS. So HEV interval is negative 45 millisec. We conduct V pacing. There is no VA conduction. We pace atrium. Yeah, you can see the delta wave augmentation after atrial pacing. Let's compare it with this delta wave and sinus rhythm delta wave. Also, HEV interval is more negative during A pacing. This is his onset of QRS is here. We conduct multi-site A pacing, high atrium, low atrium, and left atrium pacing. Even multi-site A pacing, delta wave morphology, no change. We inject adenosine. As you can see, AV block appeared just after adenosine injection. Okay, we conduct his bundle pacing. Yeah, this is normal sinus rhythm delta wave. We pace the his bundle like this, and his bundle pacing made QRS narrower. That means disappearance of pre-excitation by his bundle pacing. So in this patient, AV conduction is decremental, VA conduction no VA conduction, pre-excitation degree has been changed by atrial pacing, HEV interval is negative and changed and negative. Adenosine injection induce AV block and multi-site A pacing no effect, and his bundle pacing induce still pre-excitation. No pre-excitation. No tachycardia was induced. We did not ablate this pathway. So this patient has nodoventricular access pathway. When it comes to nodoventricular, nodovascular pathways, QRS morphology is different. Ventricular insertion of nodovascular pathway is RV apex. However, ventricular insertion of nodoventricular pathway is RV base. That's why the QRS morphology is different. The delta wave morphology of nodovascular pathway is typical vascular block pattern or ABB pattern, however, does not. And during the tachycardia, we can conduct a V entrainment pacing in nodovascular pathway. V entrainment pacing may result in no progress fusion. However, in nodoventricular pathway, we can see the progress fusion by V entrainment pacing. This blue fiber is nodoventricular pathway. Next case, 15-year-old male. He complained of recurrent palpitation. His ECG tracing shows delta wave. So we conduct catheter ablation EP study. During sinus rhythm, this is his bundle. HEV interval is much shorter, 8 millisecond. We conduct V pacing, however, no V conduction. We conduct A study. During A pacing, delta wave is augmented. Let's compare with this one and this one. And HEV interval is shorter during A pacing. We inject adenosine. However, just after adenosine injection, still no AV block, still we can see the delta wave. So this patient has atrioventricular access pathway. AV conduction is decremental and no VA conduction. Pre-excitation degree has been changed by atrial stimulation. HEV interval is changed after adenosine injection. We can see the no AV block. When it comes to atriovascular and atrioventricular pathway, also same story. The ventricular insertion site is different between this pathway and this pathway. So that's why the delta wave morphology is different. This is atrium and ventricle. This is usual accessory pathway between atrium and ventricle. However, unusual atrioventricular pathway like this. The atrial insertion with ring tissue. This is a node-like tissue. Next case, 21-year-old male. He complained of recurrent palpitation. His ECG tracing, nothing special. No delta wave. And we conduct EP study, catheter position like this. We conduct the single study. VA conduction was concentric and decremental. During A pacing, surprisingly, we can see the delta wave during A pacing and decremental conduction. Like this, AH interval is prolonged after S2 pacing. However, sinus rhythm, no delta wave. So we performed multi-site A pacing. High RA pacing, no delta wave. Low RA pacing, you can see the delta wave augmentation. So we performed the his bundle pacing. The delta wave is narrow, no delta wave during his pacing. Antidrugging AVRT was induced by A pacing like this. This QRS morphology is fully augmented delta wave morphology. And QRS during the tachycardia, QRS morphology is left anterior fascicular block pattern. So this patient have atriovascular accessory pathway. AV conduction was decremental. VA conduction is also decremental. Pre-excitation degree has been changed by HR stimulation. HV interval has been changed. Multi-site A-pacing leads to change in delta wave morphology. His-band pacing results in no pre-excitation. Antidromic tachycardia was induced. So we ablate this pathway. This is accessory pathway potential here. Here we ablate at this point. We successfully ablate this accessory pathway. This is atriovascular pathway. The proximal insertion sites is ring tissue, node-like structure. That's why this accessory pathway has decremental property. Next case, 46 female, she complained of recurrent palpitation. Her ECG tracing, you can see the delta wave here. We conducted V study. VA conduction was decremental, concentric and decremental property. Just after V pacing, you can see the junctional rhythm, narrow QRS junctional rhythm. This means almost same to his-band pacing. After junctional rhythm, sinus rhythm resumed, we can see the still delta wave. We conduct A pacing, delta wave was augmented. We performed multi-site A pacing. This is CS910, proximal CS pacing, and this is high RA pacing. You can see the delta wave augmentation during high RA pacing compared with the proximal CS pacing. We conduct his-band pacing. During the his-band pacing, delta wave become narrower. So, and antidromic AVRT was induced by atrial pacing like this. This QRS morphology is fully augmentation of QRS delta wave. So this patient has atrioventricular accessory pathway, VA conduction decremental, and pre-excitation degree has been changed by atrial pacing. HV interval also changed. Multi-site A pacing results in change in delta wave, and his-band pacing, no pre-excitation. Antidromic tachycardia was induced, so we ablate. Yeah. This is the accessory pathway potential here. Here we ablate this point. Yeah, we successfully ablate this accessory pathway. This is ECG after catheter ablation. We can see no delta wave. This is a summary of my presentation. If we observe the presence of delta wave and AV conduction is decremental and V conduction is no or decremental conduction, we need to be suspicious of unusual accessory pathway. So we need to observe pre-excitation degree during sinus rhythm and A pacing and measure the AH interval and HV interval during sinus rhythm and A pacing, and we need to compare. And then we conduct A pacing, multi-site A pacing, adenosine injection, and his-band pacing, and then we need to make a comprehensive diagnosis, and we need to decide ablate or not this accessory pathway. This is summary of my presentation. Thank you.
Question, comment?
Will do presentation of how to do the presence of this properties and mostly similar, except that atriovesicular does not have a retrograde conduction, and there's a decremental AV conduction, but the HP shortens with incremental A pacing. But nodovascular and fasciculoventricular are totally different. They are blocked by adenosine. I think that differentiates the two in a short. But during all the cases presented, we were dealing with unusual pathways with integrated conduction.
Right.
Sometimes we come across concealed nodoventricular, nodovascular unusual pathways which present like AVNRT, A1B tachycardia. So how can we suspect them? And
Actually, nodoventricular, nodovascular pathway, concealed form is more common.
yes.
No precipitation.
Hmm.
So in the series with Dr. Scheinman's group and our series, so some other Dutch group, just the name of that guy, Edward,
Sterling.
yeah,
Hmm.
the first guy, the slide. He is a Dutch group. He's a Brazilian guy actually, because he used to be, young intern when I was in medical school. He is very much interested in this. So according to him, nodoventricular, nodovascular, probably 10% of pre-excitation, the rest is concealed. That's a challenge it comes from.
Hmm.
So either you have, first of all, if you're concealed, nodoventricular actually nodovascular, you don't need the atrium. So first priority, you dissociate the atrium from the tachycardia. During the tachycardia, deliver atrial premature beat, or just slightly faster than tachycardia cycle and continue pace so that you can break the link between the A and B. Okay, that's the first thing. Second, if you do S2 during the tachycardia from ventricle, especially near the pathway you suspect, which most of them insert in the slow pathway region, not the AV node, this nodoventricular pathway. So a lot of people just ablate the slow pathway. Okay, that's a practical sense. But we found several different forms. One is at the left side, the nodoventricular pathway, and then also retroaortic nodoventricular pathway. Those are tough, and those are really needed to some basic maneuver. But I guess that about 85-90% you can get away with the slow pathway ablation. So that's a matter of fact, the early paper you look at it, Scheinman's group recommend it. If you don't know what to do, ablate the slow pathway. That's their recommendation. And we disagree with that because of our case, 12 case we have, every single one had a slow axillary pathway potential. So I guess that is the difference between when they wrote an initial paper to mid 2010, 2015 versus 2020. The difference, we are mapping much better now. Electrocyte is smaller, we can discriminate the potentials better. So I think my recommendation is that try to make an effort to see whether you can find beside the slow pathway area, just a little more toward the ventricular aspect. Maybe there is a small sharp potential that you can target that. Okay, so it's going to be more ventricular aspect. Just right after the tractus annuli, as soon as you pass, you're going to see small A potential. Then look for the additional sharp potential there. And it's particularly during the tachycardia, you're able to see V sharp potential and then A. That's a classical. And then some of them you can entrain actually from there if the tachycardia is not that fast. Second is that when you do VS2 from the V, you can have a paradoxical His bundle subsequent beat potential. Either get longer, can get paradoxically shorter because you're not part of A, not part of tachycardia. So that both variations are positive response for the nodoventricular. Okay. But I think, most, as you said, the common mistake that people make that they think they have a slow AVNRT, they ablate them multiple times. And then not successful, patient keep coming back. And those patients prove that the slow pathway is probably not necessarily in a requirement to ablate. You're probably ablating slow pathway region to get rid of the thing, but then two different diseases. Okay, that's what it is. So matter of fact, our first case from Korea we did was 2 previous ablations slow pathway. Patient continue to have AVNRT pattern, long RP tachycardia. So heart rate is very slow, about 140s. So we did a map and then find that it turned out to be nodoventricular pathway. Yeah. So once you have a diagnosis, your case is over pretty quick. 30 minutes, you're done. Okay. So, now, very rare to see nodoventricular pathway insert actually in compact node. Now we know that. And so the diagram that Robert Anderson showing is old. They've been updated now. Okay. And then one particular we talked about before, Epstein patients, they have a multiple nodoventricular fascicular connections. Question is why they don't manifest all those? We don't know. but certainly the Epstein patient do have a slightly increased instance of nodal ventricular pathway concealed form especially. We had the 2 cases among those, so that's probably we are not looking hard enough. Because early study done by the Boston Children Group, they have a nationwide registry of Epstein pathway ablation. Most common was the postal septal, coincidentally. And that's where probably these pathways are. Some of them did not study carefully enough. They probably missed it. Or truly, with the age maturation, progression, compact node, and then those connections disappear. Who knows? Nobody knows the answer yet. So those are to be answered. So those are what we learned. Yeah. They're very interesting pathways. Maheim is basically you really have to find the Maheim potential to be successful, which is an atriovascular, cyclone presented. Those are usually between tragus annulus 9 o'clock to probably 7 o'clock range, most common. Yeah. Those are easily bumpable, so you need to be careful. When you start mapping, just raise the blade. So as soon as you bump it, just burn. Otherwise, you're gonna miss it. You have to bring patient back. This is pain. So I would recommend that just before you map, gear up the arm ablation, hold that up. Let's go. Okay, that's a good thing. And then advise it to you that to use the softest catheter as possible, not this contact sensor, all this 3D business, because that actually is the worst because you end up bumping. Because the electrocyte is smaller, their recording potential is not that great. You don't find that distinctive like a node, like a responder like potential. Yeah. Okay, any other question?
Tom, can you show me the Anderson's diagram?
The diagram,
The
mean?
previous one.
Huh? The multiple connection?
It just yeah.
Diagram, this one? This one?
Yeah, why there is 3 nodal ventricle connections, but the 1 fascicular ventricle connection?
3. Purple is all fascicular ventricle connection.
Yeah, but
Yeah.
why he wrote 3?
Oh no, he found
Is
in a
it-
pathology
is it-
specimen.
Is it more common? Is that due to more common?
Because of fascicular ventricular tachycardia, connections are common after the common bundle. So Anderson definition of a common bundle is the distal portion of AV node. So his definition is a little bit different. You need to read carefully his paper. So the common bundle basically distal portion of AV node to the bifurcation of left-right bundle. So
what's the difference of
you see the difference of color he put it in?
this one and this one?
Yeah, you see different
Looks like
color.
same.
It's like I'm saying, but you see the color he put it in? Darker, lighter, even lighter. Oh, you didn't look at the Korean figure quite carefully.
I see.
So he considered in his figure that true darker is a compact node. The light darker is a common bundle. After that, the branching bundle. Okay? Based on the trigon of a triangle. So read his paper, he will talk about that. So those would be very proximal fascicular ventricular artery pathway. Maybe they used to consider the Maheim fiber, true Maheim fiber, but nobody ever proved this. So I don't know. It's hard to know. And then the pink color up there is the one that we talk about, atrial cone, which is a fast pathway. You can notice the insert almost distal to the compact node and common bundle.
Mm-hmm.
So that's why Pierre is so sure able to conduct faster. So you guys should remember all this. I gave you a paper, so read it, please. It's very interesting. And then I also, if you look at the ERA publication, Edward Cerny published a series, mini-series 1, 2, 3, 4, talk about the anterosubtaxillary pathway. High, paraseptal, low, and where the trajectory is with the blade. It's very nice review. Edward Stunning is very much interested in pathway, complex pathway ablation, that guy. And I send sometime my case to him to ask him to look at it, what he thinks. Yeah. So there's 2 guys that I consider that look at these EGMs pathway-wise very good, Edward Stunning and Mel Chaiman. So whenever I have a case from Cambodia, Myanmar, I don't know, send it to them. They write a very nice review for me. So I learn a lot from them. Yeah. Edward Sternig is a Wellens fellow. He's Brazilian. He spent there over 20 years in Dutch. And then he spent a few years also Robert Anderson's lab. He's a well-equipped guy. A lot of publications about this business. Yeah. So if you read the Robert Anderson paper, he will be, most of them is a co-author. Edward Sternig. Yeah, he's really well-known in South America. Very nice guy too. So I was thinking one day maybe I recommend invite this guy to the KHRS conference. Give you guys a lecture. He's a really good speaker too. Yeah.
We see a lot of Mahim fiber tachycardias.
Yeah, I'm sure.
We induce left bundle branch
Yeah.
tachycardia, and it turns out to be
Yeah,
a Mahim.
typically, yeah. And the exercise
And-
uses all those, yeah.
But often we see AVNRTs which recur after slow pathway ablation. We get good junctions, but the tachycardia keeps coming back.
It's a
And
common mechanism of the physiology for Mahim fiber to enter tachycardia. So some of them have, as you said, AVNRT, some of them don't have it. It's a single FOB. Okay. So the question is, to be ablate slow pathway, obviously you have AVNRT or blade, but a single echo, we do not have to blade in our series. So obviously I don't that many. I don't know, probably about my lifetime, maybe 11 or 12 Mahim so far. And many of them have to have another conduction, by the way. Okay. Just to let you know. But I have not had any case that induced AVNRT. Single echo, quite common. Yes. I know some other guys, they did induce a dual tachycardia as well. So, especially when you have a VA conduction time jump one to another back and forward, then you can figure that out. The tachycardia cycle suddenly lengthened. Yeah. And left side of nodal ventricular pathway, he mentioned that if the left side is one, often they develop functional left bundle. So when you look at the narrow complex left bundle tachycardia length 40 milliseconds longer, then you know it's the left side. That's a clue. Like Kumail's law, Valle's law, valid in the nodal ventricle as well, even though concealed decremental. Okay. So think about that as well. So that's how we made the diagnosis of our case, and Dr. Shamus also described it the same way. So he just some variation there. Okay, thank you so much. Good work.
Okay.
Okay.
Long weekend.
Thank you. I won't see you guys for a while. Probably I'll be in the